So the things that can cause hypothyroidism, the main one is accidental removal of the parathyroid, or the accidental removal when you remove them, or radiation to treat thyroid cancer, because it kills the thyroid, so you don't produce thyroid hormone. It can be autoimmune. It can actually be the cancer itself. You old and you're just not producing thyroid hormone, okay? Or something's wrong in my hypothalamus and I'm not producing thyroid stimulating hormone. So can you see how they all kind of overlap? But something happened in my process of my feedback circle that's causing me not to produce thyroid hormone. And you'll have this slide. Did I put that on the handout? Did I type that out? I thought I did.
Not all of it, but some of it.
It's all good.
Okay, so what do you think I need to think about with this one? I'm taking care of Grandma. She came from the nursing home.
Keep the room warm. Do you need to increase the calcium?
Why do I need to increase calcium on her?
Because she might, he said that she might have the removal of the
No, that's
That was for the parathyroidectomy.
Yeah.
If I took out the parathyroids accidentally. But she's got hypothyroidism. She came from the nursing home. She didn't have surgery. Her thyroid's just old and worn out.
She gonna need some.
Keep her warm. She's gonna want her room nice and warm, lots of blankets. What else?
Stool softeners.
Okay, stool softeners because she's constipated. What about her diet?
Increase it or like offer food as often as you can.
I want to offer
calorie,
her.
high
I want to offer her things that she likes. I want high fiber because of the constipation. Does she need a lot of calories?
No.
Nope, because she's not burning many calories.
Nope.
So she doesn't need a big calorie load.
Yeah.
Yeah. Why would I do that? I'm giving more fiber. She has constipation. I want her to increase her fluids.
So
What'd you
she's
say?
gonna
Fluids help with constipation.
Right. It'll help with the bowel movements.
go- Would you increase her protein, like for energy or anything like
You
that?
could. She's gonna eat what she wants though, because she's
Yeah.
never hungry.
True.
Okay, dry skin. What do you want to do about that? Moisturize. I want to lotion her up. If I'm giving her a bath, do I want to use harsh soap?
No.
No, I want to use nice mild soap with moisturizers in it. What else do you think I need to think about?
encourage her to
The temp of the water can't be too hot either.
Okay, because her skin's real fragile anyway, and
Yeah.
she's dry. I don't want the water to be hot because that dries her
Skin
out.
breakdown
even more.
then if she's dry.
Skin breakdown. What did you say?
encourage the patient to lose weight.
Okay. I would like you to lose weight, but you have no thyroid hormone. You think that's going to happen?
No.
Nope.
Because I'm not eating hardly anything.
Yeah.
I'm still putting on pounds. Once I get you regulated with your levothyroxine, then I would like you to try to lose a little weight. But until they have some more energy, and until they have some thyroid hormone to burn calories, that's not going to happen. It's a great suggestion, but not right this minute.
So avoid sedatives.
Okay, my doctor, every time I go, he's like, you need to start walking. I'm like, oh, what? It's not going to do anything.
Walking is good for you.
Just like somebody takes you.
How often? Yeah, okay.
How often what?
I was gonna say, do you walk? Cause I don't. Just from the car to here. That's all I'm getting.
I'm at the gym every morning. 5 o'clock.
Must be nice. I wish I could.
You could like secretly put it out there on Craigslist, just like I'll pay you if you just randomly start chasing me. You know what I'm
So,
saying?
okay, what do you think about cardiac wise? You think I need
I
to
might
be
get some
concerned at all?
exercise that way. Chasing with a chainsaw and I'm running across the yard.
If you guys miss this, I'm going to be mad. She may have some bradycardia, so I want to monitor her heart rate. Do you think she might have some heart rate rhythm changes? Yeah.
Yeah.
So if she's in the hospital, she needs to be on a telemonitor. Can you see how it's kind of the same, but for a different reason? Somebody said something about sedation.
Yeah, avoid sedatives.
Okay, why do you think they need to avoid sedatives?
Because their body don't metabolize them right.
Right. They're not
They can get
metabolizing things
over-sedated.
correctly. And so where if I gave a normal person with normal thyroid function morphine, they metabolize it, they're good to go in a couple hours. If I give this person who's not metabolizing it the same amount of
Be knocked out for
morphine,
way longer.
they're knocked out for way longer, they're less responsive, and then my airway becomes an issue, that they're too sedated. They hold on to it and it's way more effective for them. So we want to use caution with those. You told me low calorie, high fiber, and increased fluids. So I think you got everything.
So for pain, would you use like NSAIDs for that patient? Just no no opioids?
Yeah.
What
And-
about for her, the bags under her eye? Does it affect vision?
Mm-mm. Nope.
So if we had a priority question on this, what would be like a platform for this patient?
Some lab
Making sure
levels.
that she's
Well,
Heart.
if I'm getting in level 2, I'm gonna ask you things about her diet. What do I need to think about when I'm giving her diet? If I'm giving medications, which one of the medications do I need to be most concerned about with her? And that's always gonna be your narcotics and your sedatives. So things like that.
Would she be a walrus?
Mm.
Yeah, she could be a fall risk. All of these people could be a fall risk. But if she's already slow and she's fatigued and there's a lot of stuff in the hospital room to trip over, absolutely. So, you got the things. This is your drug. This is your one and only drug besides insulin and diabetic medications. Do you think there's going to be a question about this?
Yes.
Or two?
Yeah.
Okay. So, levothyroxine. Tell me what you remember about it from level 1. Brand name is Synthroid.
Take it
Okay.
at AM.
Its brand name is Synthroid. So your patient's gonna say, I need my Synthroid.
And
But
you're
what's gonna
say
be on your test?
Levothyroxine.
What's gonna be on your NCLEX?
Levothyroxine.
Levothyroxine. Okay. What else do you need? What else do you know about it?
Take it in the AM. 30
Okay.
minutes before meal.
Tell me something you know about it since you laughed when I said level 1.
As you said level 1, I was like, nothing. for level
Okay.
one.
What do you remember level 2? Okay, same time every day, empty stomach. That is ideal. Ideally, I want this patient to take this medication in the morning by itself with a cup of water. Let me ask you a question. I work night shifts, okay? And some days I wake up at 3 o'clock in the afternoon, and on my days off, I get up at 7 to get my kids off to school, and so I forget to take it. So is it more important for me to take it every day at 6 a.m., or is it more important for me to be consistent and take this medication every day at the same time?
Every day at the same time.
Because even if I take it at 4 o'clock in the afternoon with my snack or whatever, as long as I'm consistent, I'm still getting the same benefit from it when they check my lab values. It's when I'm inconsistent and I take it 2 days in a row and then I forgot a day, or today I took it at 6 a.m. and tomorrow I'm going to take it before bedtime at 9:30. When they go check my blood level, is it really accurate?
No.
No. So consistency is the most important. But yes, if you can get your patient to take it in the morning on an empty stomach, that is ideally the best time to take it. What else do you need to know about it? No grapefruit. No grapefruit. No grapefruit or antacids, either one. Actually, if your patient is on levothyroxine, they do not want them to take any kind of over-the-counter medications without consulting with their physician first, because there's a lot of drug-drug interactions, and so they want them to consult with their physician first. What else do you need to know?
Chest pain, magnesium supplements.
Okay, what'd you just say? Hold on one second. What'd you just say?
Chest pain.
Chest pain. What about it?
reported.
Yes.
And
Chest pain is bad, people. Okay, so here's what happens. I don't have any thyroid hormone, and you put me on thyroid hormone. So my heart rate, nice, slow, steady beat, and all of a sudden I have this thyroid hormone and I have chest pain. You think I need to tell my doctor that?
Absolutely.
Yeah, so I need to tell my patient, if you have any heart palpitations or you have chest pain, you need to let your doctor know, because that thyroid hormone is stimulating the cardiac muscle to beat faster. So let me ask you this. If I go in and I have my labs drawn and mine are low, and Jasmine goes in and has hers drawn and hers are even lower, does she get a bigger dose than me?
No, they're still going to start you.
Okay, they're still going to start us at the lowest dose and then increase the dose based on our lab work. So Jasmine and I have been on levothyroxine for about 8 months now. Do you think we're going to be on the same dose?
Probably not.
No, because it's individualized. It depends on how she is metabolizing the drug and the effects that it's having for
So
her.
you would get like, what, every 3 months labs or?
Yeah, it takes, how long did they make you wait for the first lab draw? It's usually,
I go every 3 months until I had normal ones, and then it's every 6
yeah.
months.
because they regulate your prescription, and it takes a little while for it to be in your system to get a good reading. So you want consistency. It's individualized dosing for the patient. Even though we both start off the same, we may not in 8 months to a year be on the same dose. What else do you need to think about?
And then,
Okay.
4 hours before or after. A lot
Magni-
of vitamins, because they inhibit the
Yes.
absorption.
Multivitamin and magnesium in particular affect the absorption, so you want to make sure that you're telling them, don't take this with your multivitamin. That's why ideally you should take it alone on an empty stomach.
An hour before.
I had a patient one time who told me, she says, when I call you on the call light at 3 o'clock to go to the bathroom, bring me my Synthroid right then. I'm like, okay. And because she did it because she wanted her coffee first thing in the morning. So she would take her Synthroid at 3 o'clock in the morning when she went to the bathroom, go back to sleep, and then when she woke up, she could have her coffee because she took her Synthroid within an hour every
Yeah.
night, in the middle of the night. So
Oh.
sometimes you just have to listen to your patients. They really have good reasons for doing the crazy things they do. Because
I
sometimes you're just
consulted
thinking,
psych for you.
you know. but- Exactly. Okay, a couple more things you need to know about it. We talked about it being individualized. We talked about cardiac issues. We talked about not mixing it with over-the-counter stuff. What about this? Well, I've been taking this drug for 6 weeks and I just don't feel any better, so I'm gonna think I'm gonna take 2 a day. No.
It takes time to actually.
It takes time to build up in your system. Who changes your dose? You or
Doctor.
the doctor?
Your doctor.
The doctor. Don't adjust your dose without seeing your physician because they're going to adjust it. You know, you can have patients who say, if 1 is good, 2 is better. So, you know, so make sure you teach them that. You can't just adjust. It's not like taking Tylenol.
That's only with crack, sir.
Right. Yeah, you can't just adjust this yourself. Okay, let me see. What else is on here that I want you to make sure you know? Okay, one other important thing that you need to teach them about this drug is it's supposed to relieve their symptoms, their fatigue. It's not. If I get my hormones right, should my symptoms be better? Should I have more energy? Should my heart rate come up a little bit from where it is bradycardia? Should my skin start not being so dry and flaky all the time? Yes, I should see improvement. What happens if I take too much medication? I'm going to see hyperthyroidism. So, this is the biggest concept you need to understand with your hormones. If I have a hyper problem and I'm taking medication to fix it, and I take too much medication, I'm going to have hypo. And the same is true if I have hypothyroidism and I'm overdosed on levothyroxine, I'm going to have hyperthyroidism. So now you need to watch, Chelsea, because you're taking this medication and you might have hyperthyroidism from it. And Chelsea's like, okay, thanks for letting me know. Does she know what I'm even talking about?
No.
So who's going to teach them what the symptoms are?
Nurses.
So do you think you need to know the symptoms?
Absolutely.
So when I ask a question and say my patient's been on levothyroxine for 6 months and they are starting to do A, B, C, and D, what might my problem be? That they're
Dose.
over-medicated? Yeah, you might need to know something like that, okay? So this slide, super important concept, overcorrection of a hormone problem. It applies to all of the hormones, not just thyroid, but I put it here because it's the first medicine we're talking about. So if I fix one problem and I overcorrect it, I'm going to get the other problem. So my patient teaching has to include the symptoms of the other problem. Okay? This is on your sheet. This should be highlighted. Yes? Yes. This is a complication that we are going to talk about in level 4. It is myxedema coma, and it is when that myxedema that she has in her face is her hypothyroidism is not effectively treated, and that becomes too much, and it gets into her lungs, and she can't breathe. We're going to talk about that in level 4. Okay.
Oh.
What happens is they have decreased cardiac output because the heart is just in one big flabby muscle, and so then they have decreased perfusion and decreased gas exchange. So airway is an issue. Do you need to memorize this slide? No. Nope, because it's in italics on your sheet, and it ain't on your syllabus. okay? I'll tell you what's on your syllabus. Parathyroid hormone. Look at this, y'all. It's only 3 pages. 3 pages. So you can probably go find information in those 3 pages if you don't understand something. We're going to talk about parathyroid hormone. See, this is the front. Those are on the back side of your thyroid. You got 4 of them, okay? And they help regulate your calcium in your body, okay? So on your sheet, what did you have starred? Did you have calcium starred? Somebody tell me, okay, somebody tell me what calcium does first. Okay, bones.
And it's also
Contract
found in the
muscles.
blood, muscles, and other tissues.
Beats our heart.
Okay, has to do with cardiac, the calcium channels in your heart. What did you just say, Tabitha? You
Oh,
said something.
I said in the muscles and your other tissues.
Okay, it has to do with your muscles. What's it have to do with your muscles? What does it do to your muscles?
Contract.
Okay, so if you, here's how I want you to think of calcium. Okay, I want you to think of calcium this way. Calcium is a cell membrane stabilizer, and if I have too much calcium, it sedates all of those cell membranes and all of my muscle cells. So without even knowing anything about my patient, if I have too much calcium and I'm sedating the muscles in my bowel, what do you think my symptoms are going to be?
Constipation.
Constipation. If I'm very spastic, what's going to happen to my muscles? I'm going to have muscle spasticity. I know that you all learned about Trousseau's sign and Chavassi's sign. That's this patient. We're going to talk about these with this patient right here. Okay? So, let me go back here. It maintains your calcium, and let's talk about parathyroid. It maintains that calcium balance, okay? You have that on your sheet, someone?
Mm-hmm.
Okay? You know it works in the kidneys? Did you find that somewhere in the book? It works in your kidneys by increasing calcium reabsorption. So instead of excreting calcium in the urine, you're hanging on to it. It helps you hang on to calcium. It assists in bone reabsorption. It breaks down your bones. The PTH breaks down your bones to increase calcium. So when you look at your negative feedback loop, the problem starts when your calcium's low. Your body says, your parathyroids say, the calcium's low, we need to figure out a way to increase the calcium, and it releases parathyroid hormone. So when it does that, it does a few things. It works in the kidneys. It helps you reabsorb calcium. So instead of excreting it, it helps you hang on to calcium. So without knowing anything else, and you had excretion yesterday, now I'm holding on to calcium, what's my problem? What's my problem going to be? Kidney stones. They're at a high risk for kidney stones because now I'm holding on to all this calcium and it's building up in the renal tubules. It's breaking down my bones because I need calcium from somewhere. It's going to break down my bones. What's happening to my bones?
Osteoporosis.
I'm getting osteoporosis. They're getting fragile. I have a higher risk for fractures. Can you see how this patient's going to be an injury person? Can I have problems? Then it also, PTH also works in your gut to activate vitamin D. Because if I don't have vitamin D, I can't absorb the calcium anyway. So if I don't have vitamin D, then those other 2 things don't matter. So it works on those 3 places, the kidneys, the bones, and the gut, okay? Oh, I didn't want to give you the lab. I don't want you to know the value for parathyroid hormone. I just want you to know which way it goes when we talk about it. I don't want you to know the value for vitamin D. I just want you to know that it's important to calcium regulation. I do want you to know the normal for calcium. So somebody tell me the normal for calcium. 9 to 10.5 is the normal. I'm not going to trick you and ask you something super close to that. It's going to be like 11 or 12 or something. What about phosphorus?
3 to 4.5.
Okay, 3 to 4.5. That is what your book says. And what about magnesium?
1.3 to 2.1.
Okay, 1.3 is really low, and in the hospital, that's probably going to be something it's going to be low. But your book does say 1.3 is the bottom. Okay, you don't need to know the lab value of PTH. Okay, and they're gonna be on your slides when I publish them tomorrow afternoon. So you'll have them, the ones that I'm gonna use if I write test questions with them, okay? So we talked about calcium. Calcium acts as a membrane stabilizer. Think of it as sedation if it's too much, or excited if it's too little, okay? My muscles have to go find some calcium somewhere. It's the building block of bones. So you know if I'm breaking down your bones to produce more calcium, your bones are getting brittle. And it plays a role in blood clotting. Y'all told me all of those things, so good job looking them up. So, which way are my labs gonna go? My patient's cycle's broken.
Your PTH is up, your calcium is up, phosphorus is down, and your mag is up.
Okay, so calcium and mag always travel together the same direction, okay?
Sorry.
So if calcium's up, your mag is up. If calcium's down, your mag is down. Phosphorus is the opposite, okay? Now our cycle's broken, so normally if my calcium was high, my PTH would shut off. But for some reason, my parathyroids are still producing, so I have too much parathyroid hormone, which keeps breaking down bones and keeps reabsorbing calcium, and so my calcium keeps going up and up and up and up, okay? So that's why they're backwards. The only exception to this, and I really don't want you to get bogged down with this, is a patient who's on dialysis, you might see the parathyroid be super high, but they can't produce the calcium because their kidneys don't work. But for our patients in level 2, they're both gonna go the same direction, okay? I'm trying to make more, and I already have too much, okay? So let's think about what's happening. We said calcium affects the heart. What do you think's happening in the heart? Dysrhythmias, because calcium, you know, calcium channel blockers. There's a calcium channel, system in your cardiac system that controls your heart rate and controls the rhythm. So if I have too much calcium, I'm going to have some cardiac problems. What else do you think is happening in my
Kidney stones.
Okay, kidney stones, because I'm retaining all this calcium in my kidneys, and I have a potential to develop kidney stones. Okay. What do you think is happening in my digestive system? Slow. So I have constipation. It also causes some abdominal pain because it's constantly irritated because the calcium's too high. Musculoskeletal, what do you think is happening?
Getting very fragile and breakable.
Fragile. Yeah.
Okay, yeah, well, I'm getting brittle bones.
Good.
So when I'm taking care of my patient and I'm walking them down the hall and I'm not using the gait belt that I didn't bother to go find, and they fall and I grab them, what do you think happens to their humerus? I can break it, you know, or they fall down in the bathroom because I didn't give them their call light and they had to pee. You know? It can, but that's different than parathyroid hormone. Same symptoms though. Yes, because calcium can decrease your level of consciousness. So you can have a decreased level of consciousness, LLC. Let me think what else I got on my list. We talked about nerves. We talked about cardiac. We talked about the constipation and the belly pain. Risk of fractures with osteoporosis, and we talked about kidney stones. So here's our little picture of our lady. She's got her digestive problems. I'm assuming that's a lady, I don't know. She got some muscle weakness and muscle aches from the calcium, her nervous system problems, bone and joint, and kidney stones. So that covers it all but cardiac. Yep. Because the calcium creates more pepsin in their GI tract, and it causes the nausea, vomiting, and abdominal pain. So there's your little picture with your symptoms. Here's your most common thing, a tumor on the parathyroid. So you can correct that by removing the tumor. And we're going to talk about that surgery in a minute. Neck or trauma radiation. So I had thyroid cancer and they did radiation to my thyroid. Do you think they can avoid your parathyroids? No, they're right there in the path of it so that you can destroy them with the radiation. Our chronic kidney disease person, I'm just going to tell y'all, dialysis patients are like the worst patients to take care of electrolyte wise. They have all kinds of
Nothing
weird
ever is right.
problems. And they come back from dialysis and they feel great, and then you go in and they crash in the middle of the night. They're always your outlier in these problems. Because their labs are just never
Good.
they're just never right. So if you have a situation and it's a chronic renal patient, it may not be the normal situation. We're talking about the normal patient in here. You might have a tumor in one of these other organs that secretes parathyroid hormone. So those are the causes that you're going to see. I'm not going to ask you that. That's an anatomy question. You know what I mean? We're not in anatomy. We're in nursing school. So I'm not going to ask you like that, but I want you to know what could cause the problem. So what do you think you need to think about when you're nursing this patient?
Heart monitor.
Heart monitor, because my calcium's high. I want to make sure I'm not having any kind of dysrhythmias.
Increase fluids. High fiber.
Okay, increase fluids for
Kidney stones.
kidney stones. I want to increase fluids for the kidney stones. Is that going to hurt my constipation problem?
No.
No,
It's
it's gonna help
probably going to
it.
help it.
You can
So
increase-
increase fluids.
You can increase their phosphorus.
You can increase their phosphorus. How are you going to do that?
Alright, green.
Calcium.
Green leafy vegetables are high in phosphorus. Here's the problem with that. Let me just have the problem. Are they also high in calcium?
Yes, they are.
So
They're not supposed to have them for
Just
kidney
don't cross
stones.
that
right.
off.
So you have to be real careful with their dietary considerations. What about dairy?
No dairy.
No
Dairy is high in calcium.
Calcium.
It's also high in phosphorus. So these patients can't have dairy. So you have to be real careful what you give them or what their diet is. Does that include, that take a lot of teaching?
Yeah.
Yeah, it takes a lot of teaching because we don't even know what has fiber in it. So, you know, we're
A lot
still
of
learning.
plant proteins have calcium in it.
In general, we should say increase phosphorus or no?
Well, you can increase their phosphorus, but how are you going to do that?
Right.
I mean, yeah, how are you going to do that? They can take a phosphorus supplement
Just give them water.
Ice chips.
or ice chips. She wants to go with ice chips only. What else do you think you need to think about?
Fluids.
So we talked about fluids for the kidney stones.
Yep.
We talked about fluids for the constipation. Cardiac fall risk. Fall
Oh,
risk.
that's right.
Safety. So what if you go in and you see two nurses' aides pulling your patient up in the bed, and you know sometimes there's no draw sheet, and I'm too lazy to go get one. So you just grab her underneath the arm on that side, and I'll get this side. Think that's a good idea with her?
No, you're gonna break
No.
everything.
No, she's fragile. We don't want to do that. So, what do you think this person needs to know about exercising? Low impact. So I don't want them to be sedentary because what's that do to my bones?
Makes them worse.
Makes them break down even farther. So I want you to do some low impact walking, swimming. Well, I can't walk more than 10 feet because I'm 90 years old. Is sitting in a rocking chair a low impact exercise for that
Yes.
grandma? Just rocking back and forth? So things like that you need to think about. Let me make sure that you hit everything on my little list that I have here. I don't want you to get to the test and say, she never met the math. Because some of us, well, somebody in here needs to talk about it at some point in time. We talked about that. We talked about no milk and dairy and PO fluids. Okay, so you can probably take care of that. These medicines right here, are they yellowed out or grayed out?
Yeah.
Those are medicines we're going to talk about level 3, the bottom ones. I do want you to know that if your patient comes in with this problem, they're going to give that patient some diuretics. Because if I give you some diuretics, some Lasix, and you're peeing more, you're going to pee some calcium out. So we're going to try to lower it that way, but we're going to try to give you some IV fluids to dilute, make the calcium dilutionally lower. Because that'll help fix the problem. So if I'm talking about giving this patient Lasix, a diuretic, what kind of things do you think I need to think about?
Then that, go to the restaurant.
Okay, say it again.
Then getting up to go to the restroom.
So we already know she's a risk for injury if she falls. And there's SCDs here, and there's an IV pole to trip over, and that nurse before me left some IV papers on the floor.
Can you put
Do I
a
need
potty
to
chair
do
by
something
their
about
bed? Can you put the bedside commode next to them?
You could give them a bedside.
Or just clear out clutter?
If it's a male, you just give them
I would
make
make
sure you
sure
give
you
them call light.
Yeah, make sure you give them the call light. So those are the kind of things I want you to think about. What kind of labs do you need to think about if I'm giving diuretics?
All of them. All the
Potassium in
electrolytes.
particular, because it's not potassium sparing, and so they could deplete their potassium also. I'm diluting it, and they're peeing, so my potassium is probably gonna drop. So those are the kind of things I want you to think about, nothing specific. You know what I'm saying?
Did you report a low potassium? Like, if there was like a question on the test, like what?
Well, would you?
Yes. Because can't they have a seizure?
If you wouldn't, I don't want you to be my nurse. Yes, if your patient has hyperparathyroidism and is receiving a diuretic, and I give you a potassium that says their potassium is 2.8, yeah, call the doctor. Do something. I mean, don't just put a star by it.
We'll come back to that one later.
Give them water.
Yes, I'm going to use a generic diuretic, but the safety would be with the diuretic. So either an ambulation thing or a lab thing, something like that. A parathyroidectomy is taking out the parathyroid. Normally, they only have to take out the parathyroid that's causing the problem. Okay? But if they accidentally remove them all, like when they did your thyroidectomy, they can actually implant one of these in your forearm, and it will actually it will,
Take one of your own and put it there?
yeah, it'll make blood supply, and it'll still produce PTH. They usually do this just as a little needle biopsy kind of thing. It's real small. So if it's open, it's the same things as the parathyroid, or as the thyroidectomy. But if it's closed like this, they usually do it and send you home. What kind of labs do you think I need to check? I just took out your parathyroid. I need to check your calcium level because I just disrupted the process, and your calcium level could be low now. So I need to be monitoring their calcium. Usually when they have this, they actually draw a calcium level in the operating room before they bring the patient to you, and then they draw one 8 hours later, and if it's good, they let the patient go home. Because usually you're going to know within 8 hours if the calcium is going to drop. So just think about what you need to think about with this patient. So low calcium and things like that. Your regular surgery. These questions aren't tricky, y'all. If they're a surgery patient, does it really matter? The answer is always early ambulation. You know, unless they didn't ambulate. You know, and airway. Those are the two most important things you can do for a surgery patient.
The amputation is airway. If it's anything else, ambulation.
Right. Okay, so the complication is a hypercalcemic crisis, and this is life-threatening. The calcium's just too high. Do I have that grayed out on there? Because I think it's Let's talk about it real quick. I'm not going to ask you about this in level 2, I promise. It's not grayed out, but I won't ask you. They do dialysis on this patient because you cannot get rid of the calcium fast enough to fix the problem. So they actually dialyze the patient and pull the calcium off that way.
Wow.
And they have to find the underlying cause and treat the underlying cause. So just know that if the calcium gets too high, it can cause a lot of problems, and this is what they do for that patient. But I promise you, there's no question on your test about that, okay? And you'll have the slide. Let's talk about type O parathyroidism, because I want to get this done today because we have a bunch of stuff to cover tomorrow. Diabetic stuff's the biggest. How are my labs going to look? Type O parathyroid. Which way is that one going to go? PTH.
Low.
It's going to go down. Which way is my calcium going to go? Okay, so in this disorder, they travel together. Okay? My calcium and my PTH always travel together in my disorders. So, I mean, that's a giveaway. If it's hypo parathyroid, it's also hypocalcemia. So my labs are the exact opposite they were before. So, given what you know about it, what do you think this guy's problems are going to be?
Dysrhythmias.
Okay, dysrhythmias, that's a big one.
Overactive DTR.
Positive phosphate.
Okay, overactive deep tendon reflexes. What else?
The positive
positive Chvostek sign, that's the one where you tap on this nerve right here and your patient's face will twitch. They can't control it. You can't do anything about it. And when they take your blood pressure, you know, even when they take your blood pressure, your calcium's normal, your hand kind of tends to curl up a little bit. Well, when you have low calcium, you'll see that hand come all the way. There's nothing they can do to stop it. And that's Trousseau's sign. So that's the symptoms of hypoparathyroidism, but really it's a symptom of hypocalcemia. So you already know that from fluid and electrolytes. So anytime you think of hypocalcemia, you know it's hypoparathyroidism. So let me ask you this. What do you think your patient's first complaint? I just accidentally removed your parathyroids because I'm a terrible surgeon and I took them out with the thyroid. Okay? What do you think their first complaint's going to be? Tingling. Where?
Your
Tingling.
Fingers and toes.
mouth and toes.
It's usually around your mouth. They're going to say, I don't know why, but my lips feel like they're numb. They're all tingling. Then your fingertips and your toes. Okay? And so if your patient calls you on the call, like they just had a thyroidectomy, and they say, I don't know what's wrong with it. I'm just all, my lips are tingling like they're numb. You might want to let the doctor know, and he'll want you to draw a calcium level. Okay? That's the first thing they complain about. If that gets too bad, then you have the muscle spasms, and you can have tetany. So, what is tetany?
Or bronchos.
Being cramped up. Okay, it's the same thing as tetanus, tetany, where you get cramps, uncontrolled cramps. When do they become a problem? When they constrict what? One thing in particular.
Their air.
When they constrict my airway, that's when they become a real problem. So laryngospasms and bronchospasms are a late sign that you got a calcium problem. So when your patient says, I'm all tingly around my lips, that's like an indicator that you might need to do something. Okay? Because when they can't breathe, it's kind of too late. So keep that in the back of your mind. Cardiac changes, you talked about those. We talked about Chvostek's, we talked about Trousseau's. See, I don't need these notes, but I have them here because I do know what your test questions are. I want to make sure you cover everything. Here's your little symptoms here's your thing of symptoms. These are the ones we talked about.
They both were going to have.
They have some emotional things going on too from calcium. Can you have seizures if your calcium's too low or too high? Yeah. So I need to be, neurologically, I need to be assessing and seeing what's going on. But I gave you all the hints up here as to what's going on with you. We talked about this, the destruction of the parathyroid glands, either from removal or from radiation. It can be hereditary. You either just don't have parathyroid glands or there's some problem there. This one, resistance to PTH, means that your kidneys just aren't receptive to it, so it doesn't hold the calcium in the kidneys, and so it's just, it doesn't work because your kidneys don't work. That's where your dialysis patients come in. Autoimmune. If I have hypomagnesemia, that can cause this, because remember, magnesium goes the opposite way of my calcium. So who's typically that patient? Alcoholic patients who come in the hospital.
You said it's
Yeah, they go together, I'm sorry. They go together. Phosphorus goes the opposite. So if this is low, my calcium's also low, but this is usually your alcoholic patient who is nutritionally compromised, and magnesium's their biggest electrolyte that's always out of whack. And you'll see that they have low calcium because of the low magnesium. Mike, I can ask you those. Those are anatomy questions.
Can being immobile cause it too? Being immobile, like by being able to move, immobile?
It can, but if I'm immobile, my bones are breaking down, so I'm continuously.
Like hyper, but
Yeah, once your bones are broken down a lot, yes, it'll become hypo. Whoops. Okay, what do you want to do for this patient?
Heart monitor.
Heart monitor. Can you see that they all need to be on heart monitors? Yeah. If you have a calcium problem, or if you have a thyroid problem, and you're in the hospital, you need to be on a heart monitor, okay? Because they can cause cardiac changes. What else do I need to do to take care of him? Okay, airway. I want to make sure that if he tells me he's numb and tingly, I don't let him get to the point where he's whistling because his airway's, you know, so small. You know what I'm talking about. I would do it, but it makes my throat hurt. What else do you think you need to think about? Seizure precautions. Who said that? Okay, seizure precautions, because if my calcium's too low, it can cause neurovascular changes and my patient can have a seizure. So I want to think about my seizure precautions. So we talked about all those with cognition. Mainly, I want to think about safety. What is safe for my patient if they have a seizure? What else do you think I need to think about?
Increased calcium.
Okay, increased calcium. How am I going to do that?
Diet.
We're going to talk about the medicine in a minute. That's not on your syllabus though, so don't get lost there. What do you think I want to include in the diet?
Geary.
Dairy's high in phosphorus and dairy's high in calcium. My phosphorus is already high. Salmon, nuts, things like that. You want to black beans. You want to include things that are high in calcium but not in phosphorus. I'm not going to ask you real in-depth big diet questions because I know you already don't know that, and I'm not giving you points back. Just saying, okay? Monitor their airway. Let me ask you a question. I just took out your parathyroid glands. You have this calcium problem. I want you to take this calcium supplement and you're going to be okay. Is that true?
No.
Is this a lifelong thing?
Yes.
Yes, this is a lifelong thing. It doesn't just go away. I did something to your parathyroids. I got to figure out how I'm going to replace the calcium. Okay? So you need to teach your patient it's lifelong.
Would you also something like vitamin D for absorption of the calcium?
For the absorption of the calcium, they do have, yes.
How about eat Tums?
So this right here, yes, who has eat Tums?
Me?
Where'd you get that at? In your book?
Jesus? Yeah.
That is what they do. They put it in a cup and they say, here's a medicine cup full of Tums. When the commercial comes on, I want you to eat these Tums. And they constantly eat Tums. That's how they replace their calcium. It is calcium. So I'm eating so much calcium, so now I have the other problem. I'm constipated,
Yeah.
and, you know. So, I mean,
David puts in
eating
his
Tums is
plants
like
when
eating
a
chalk.
calcium
I mean,
deficient.
here's your medications.
We got 2 week ones.
Yep, sticks it down in the dirt.
Yeah,
It dissolves.
here's your
It goes in the
medications. Do I have these grayed out?
There's none.
Okay.
Yeah,
Well,
we don't have no medicine.
you don't need it. You need to know these. Just in Tums is your oral calcium replacement because they're absorbed faster than, you know, the calcium with vitamin D. So if my calcium is low, I want you to eat those and bring it up faster. Phosphate binders you're going to talk about in level 3 with your dialysis patients, and that medicine is called Renagel. And what that does, it binds with the phosphate. They poop out the phosphate, and in the process of bringing that phosphate down, what happens to your calcium? It goes up. It goes up. And then in emergencies, you're going to give IV calcium gluconate. If I'm going to give IV calcium, what do you think I need to think about? I need to have them on a heart monitor. I need to know how fast I can run it, things like. Do I want you to know specifically that you can run it at 25 cc's an hour? No, I do not. What, they make a good math problem on your test, though.
I mean, that's
That would involve having a
Yeah, I'm actually okay with that. Like the rest of
all of those.
Just put the math on there and not the diet.
50 questions complications you're trying to prevent. I'm trying to treat this patient before I get to the point where I have cardiac arrhythmias and seizures and a closed off airway. So I need to be cognizant of what's going on with my patient. I need to listen to their complaints when they say I'm having numbness and tingling. I need to be checking that cardiac monitor. I need to be looking at their daily labs. Or if the doctor orders calcium level every 8 hours, I need to be drawing it every 8 hours, not every 16 hours, because it could change a lot in that delay period there. So, do you think you could take care of somebody who has a calcium issue? Okay? Think about your stuff. Think of any questions that you might have. We'll answer them tomorrow. And we'll cover these last 3 things tomorrow. Okay?